Alright guys, in this short video, I'm quickly going to discuss your FMGE January 2025 question paper. So there is always a high probability of previous year questions, if not questions, previous year topics getting repeated. So it is very important if you are preparing for your NEET PG or FMGE exam, because the exam taking body is same, which is NAT board. Alright, so let's start with the first question. A corneal wisp test was performed and the corneal reflex was elicited. Which of the following nerves is responsible for the afferent limb of this reflex? So you know, here we are talking of which reflex? We are talking of blink reflex, and any reflex in the body has got one afferent and one efferent. So afferent of the blink reflex is formed by your trigeminal nerve, the ophthalmic division of trigeminal nerve, while efferent is your facial nerve, because when you touch a cotton wisp onto the cornea, so there is subepithelial plexus of nerves which gets stimulated, and via this there is long posterior ciliary nerve, and we have got nasociliary nerve, and we have got ophthalmic division of trigeminal nerve forming the afferent, and then efferent is seventh cranial nerve, due to which there is orbicularis oculi stimulation, so which will contract. So afferent, if they have asked, then the answer is pretty straightforward. It is trigeminal, and facial is your efferent limb. Of course, I'll not be showing you the real patient cotton wisp reflex videos, but that's okay. The idea will be to give you the entire conceptualization of the topic. Okay, now coming over to the cover uncover test is performed to diagnose various eye conditions. Yes, of course. Which of the following is not detected by this test? You already know. Cover uncover test is you cover one eye and you look out for the movement in other eye, so that is for tropia. Cover uncover is done for phoria, and you look out for the movement of this eye on removal of the cover. So it can be used for latent squint, which is phoria, manifest squint, which is tropia, and also cover uncover test can be used in identifying amblyopia. Amblyopia is lazy eye. Okay, so the answer is pretty straightforward. It is your latent nystagmus, for which cover uncover test is not used. Okay, which of the following is a side effect of prostaglandin analog? Mind you, PG analog is drug of choice for primary open angle glaucoma, primary angle closure glaucoma, also normotensive glaucoma. Earlier, the drug of choice for primary angle closure glaucoma was pilocarpine. Earlier, the drug of choice for primary open angle glaucoma was timolol, but now it is prostaglandin analogs. Why earlier it was something else? Because prostaglandin analogs used to cost nearly 1500 rupees for 3 ml bottle. Now it costs just 250 rupees for 3 ml bottle, and the patient is able to put it because it is only one dosing. So you know, patient is able to remember the timing of the dose. So at night, always ask the patient to put this drop after having dinner at night. Okay, so now what will be the side effect? Important side effects, I am writing it here, then we'll look out for the options. One is your trichomegaly. Trichomegaly is increase in the length and coarseness of eyelashes. I know this is kind of very atypical side effect. So yeah, so that is your trichomegaly. And then there is iris hyperpigmentation. Other side effects include cystoid macular edema. Then we have got uveitis, which is there in your option. So that is your uveitis, which can be marked here. Okay, so but you need to remember the remaining three side effects, and also it can lead to reactivation of herpes simplex virus. Okay, all right, now coming over to the next question. A 5-year-old child presents with a refractive error of 1 diopter in left eye and -2 in the right eye. Fundus examination reveals normal visual acuity and retinal findings. Which is the most likely diagnosis? So can you appreciate? +1 left eye, okay, right -2. What is the difference in refractory error between two eyes? Can you tell me? So +1 to 0 to -2, it is 3 diopter is the difference, है ना? And that the vision of the patient is relatively normal, and of course retinal findings are also normal. So what is this? When there is difference in the refractive error of 2 eyes. That is your definition anisometropia. Significant anisometropia is when the difference is more than or at least 2.5 diopter. 1. Now this anisometropia can lead to amblyopia. Now you would say, sir, why the answer is anisometropia? Why not amblyopia? Had they had mentioned that visual acuity is not normal, it is decreased, then it would have been amblyopia. Which amblyopia? Anisometropic amblyopia. Now based on what is given, it is a clear-cut answer, which is your anisometropia. I hope you are able to connect the dots. Okay, next, a patient presents with right-sided field defect in both eyes. Right-sided field defect in both eyes, but the central vision remains unaffected. So right-sided means, so this is the visual field that I am making. So what is this? Can you tell me? It is right homonymous hemianopia, can be seen in left optic tract lesion, number 1, but they have specifically mentioned that central vision remains unaffected. So actually the visual field defect is not this, it is something like this. Yes, so there is macular sparing, the central vision remains unaffected now. So this is your homonymous hemianopia with macular sparing. This is the exact term, and it is seen in which lesions? It is seen in occipital lobe lesion. Occipital lobe lesion. Why? Because all the fibers, they are reaching towards the occipital lobe, but the fibers which are coming from the macula, they are reaching towards the core of occipital lobe. What if there is posterior cerebral artery infarct, posterior cerebral artery lesion? So of course it is going to involve all the fibers which are there, but the macular fibers, since they are going till the core of occipital lobe, so the core of the occipital lobe receives another blood supply, that is from middle cerebral artery, so that is why there is typical sparing of the central core of the occipital lobe, which is receiving the macular fiber. So there is homonymous hemianopia with macular sparing. Okay, all right. A patient presents with vision problem and has a history of cataract surgery, uneven full cataract surgery. OCT finding is shown. Yes, done multiple times in my class. What is the syndrome most likely associated with these findings? So this is what? This is your cysts in the retina, and this condition is, so this is your OCT of macula, and this condition is cysts in the retina, is cystoid macular edema. Now can you tell me cystoid macular edema that happens to be after uneventful cataract surgery, and that is your Irwin gas syndrome. It happens to be nearly 1 to 3 months after cataract surgery. How can you prevent it? I always give my patients bromofenac, nepafenac. So bromofenac and nepafenac, they are topical NSAIDs that are used as prophylaxis for development of Irwin gas syndrome. Nepafenac. All right. Now coming over to the next question, but okay. Wait. Elschnig pearls, they are after cataract. They are diffused opacities on the posterior capsule. So posterior capsular opacification after cataract. Central serous retinopathy, it is leading to, it is more common in males who are middle aged, and there is central exudative retinal detachment. Yes, and Posner-Schlossman syndrome is raised intraocular pressure with uveitis. That is Posner-Schlossman syndrome, glaucomatocyclitic crisis. Okay, all right. A patient sustained blunt trauma to the eye 6 months ago, now presents with blurring of vision. What is the most likely condition? So this image was asked, what is this? Can you appreciate that there is tear of the iris from its root? So what is the definition? So there are 2 pupils, and also there is a typical D-shaped pupil. Yes, so tear of the iris from its root is your iridodialysis. Now what is ankylobraphron? It is adhesion between upper and lower lid, adhesions. Okay, what is Vossius ring? Vossius ring is seen in blunt trauma, and it is when there is pigment dispersion on anterior lens capsule seen in blunt trauma. Cycloiriditis means iridocyclitis, which is your anterior uveitis. Okay, so always and always try to answer the questions by elimination. So always and always, so ankyloblepharon eliminated, Washer's ring eliminated, cycloiritis eliminated. So this is your iridodialysis. However, this question was typically based on the definition of iridodialysis. Don't confuse iridodialysis with cyclodialysis. Cyclodialysis is ciliary body separation from its root, from scleral spur. Ciliary body detachment, yes, detachment from scleral spur, because it is the area on which ciliary body is attached. That is your cyclodialysis. Now can you tell me what is angle recession? It is also a single liner question which has been asked multiple times in your FMGE exam and also in your NEET PG exam. Angle recession, when there is separation between longitudinal and circular fibers of ciliary body. Yes, circular fibers of ciliary body. Okay, that is angle recession, which leads to back going of the iris and it will widen the angle, but that actually leads to raised intraocular pressure, because this is a telltale sign of related trabecular meshwork injury. Okay, so yes, so आगे चलते हैं. A 5-month-old baby is brought by the mother with complaints of left upper eyelid moving up and down during breastfeeding or thumb sucking, which disappears when the baby is not being fed. So that has something to do with the jaw movements, yes, which is the most likely diagnosis. So can you appreciate something which is given in the option? So let's eliminate the option one by one. If there is third cranial nerve palsy, there will be typical drooping of the eyelid, but that is not there, so remove it. If there is myasthenia gravis, so in myasthenia gravis, due to prolonged activity, there will be bilateral drooping of eyelids, bilateral drooping of eyelid, but it would not move with jaw movements. Lagophthalmos is unable to close the eyes, unable to close the eyes, lagophthalmos. Okay, now next is your Marcus-Gunn jaw-wing syndrome. Okay, Marcus-Gunn jaw-wing syndrome. Okay, so what is this? What is Marcus-Gunn jaw-wing syndrome? So there is a synkinesis. So there is a nerve which is supplying lateral pterygoid. Okay, now this nerve, which is of course mandibular nerve, which is supplying lateral pterygoid, there is misdirection and it starts supplying the levator palpebrae superioris, so that when there is jaw movement, so there is stimulation to the lateral pterygoids, yes, for mastication, and as a result the same stimulus goes to the levator palpebrae superioris. So there is winking, you call it as Marcus-Gunn jaw-wing syndrome. See, so there is synkinesis in which lateral pterygoid nerve supply goes to levator palpebrae superioris, yes, and this can also lead to seen in complicated ptosis. Your previous year question, complicated, it is a form of complicated ptosis. I hope it is well understood. So I am kind of doing rapid fire. So the idea is, the shorter the video is, the better it will be for you during nth hour revision. I don't want to unnecessarily prolong by by moving chinti ki chal. Yes, okay. Now next is a patient with a long standing history of diabetic presents with cataract. Which of the following metabolic product is primarily responsible for cataract formation in this condition? So we have done it in class. So when there is metabolism in the lens, so there is production of sorbitol, clear cut. So sorbitol is produced specifically in patients who have got diabetes and later who develop cataract. So it is sorbitol, because you know that the metabolism of the lens, अगर हम lens metabolism की बात करें, so can you tell me how much percentage is that of glycolysis? It is 85% glycolysis. Yes. Okay. 5% is HMP shunt. Okay, very good. 5% is Krebs cycle and 5% is sorbitol pathway. ठीक है? Okay, it is this pathway which becomes overactivated when there is diabetes. So sorbitol pathway, so it produces sorbitol. Okay. Now next is a patient has a history of flying foreign body injury to the eye. Ocular findings reveal iris pigmentation. Which of the following substances is most likely involved in this deposition? So iris pigmentation. So have you heard of the term inert foreign body and reactive foreign body? Out of this, glass, wood and aluminium are relatively inert foreign bodies. Okay, inert foreign bodies are those which don't induce any reaction inside the eye, but the iron foreign body, it is going to dissipate into ferrous and ferric ions, which will get deposited inside the eye at multiple structures leading to siderosis bulbi. It is this foreign body which leads to iris pigmentation, because there is deposition of this iron onto the iris as well. So the answer is iron. And can you tell me which is the most common foreign body to enter the eye? Of course, iron. Can you tell me which is the most toxic foreign body to enter the eye? It is copper. Can you tell me which is the most common form of injury by which foreign body enters into the eye? Of course, it goes, the foreign body which goes is iron, but it is your which injury? It is your chisel and hammer injury. And another important point, can you tell me which part, from which part, I mean chisel or hammer, the iron detaches and gets into the eye? Whether it is chisel or hammer, it is the hammer whose part chips off and goes into the eye. These are all your PYQs. Okay, which of the following statement is correct regarding indirect ophthalmoscopy? So there are two ophthalmoscopies. One is direct ophthalmoscopy, another is indirect ophthalmoscopy. So direct ophthalmoscopy, you have got uniocular vision, uniocularity, while indirect ophthalmoscopy you have got binocularity. Let's quickly discuss it, है ना? For details, for the real patient video, you have to watch my lecture. Okay, binocularity. Okay, and direct ophthalmoscope, the magnification is 15x. So indirect ophthalmoscope, the magnification is nearly 3 to 5x. It actually depends upon the condensing lens which you are using. So magnification formula is power of eye, which is constant. For our ease of calculation, we take it as plus 60 diopter and we divide it by your power of condensing lens. Usually we use the condensing lens of power plus 20 diopter, so it will be 3x. If you are using condensing lens of 15 diopter, so it will automatically become 4x. It is like this. Okay, and in direct ophthalmoscope, the image is virtual, the image is erect. Here the image is, yes, real, and the image is inverted. So these are important points. And direct ophthalmoscope is used for central vision. It is used to examine your peripheral retina. So central retina means central vision, central retina, direct ophthalmoscope, peripheral retina, indirect ophthalmoscope. Now getting back to our question. So which of the following is correct? The image is erect and real? No, my dear friends, it is real and inverted. The condenser lens needs to be kept close to the eye. No, not very close. You have to keep it at a normal distance. Okay. Okay. In slit lamp examination, you need to keep the lens close to the eye. Okay, and it provides 15x magnification? No, it provides 3 to 5x magnification, 15x is provided by direct ophthalmoscope, which we have just done. Okay, a patient presents with breathlessness and is diagnosed with Pancoast tumor. Pancoast tumor is the tumor of tip of lung. Which of the following finding is not typically associated with this condition? So we are talking of, yes, Horner syndrome, which is acquired. Remember, congenital Horner syndrome is seen in shoulder dystocia. When there is difficult delivery, there is fracture of the clavicles that will compress upon the sympathetic fibers which are coming from CA, T1, T2 and reaching up to inferior cervical ganglion, which reach up to superior cervical ganglion, which will loop around the internal carotid artery as a plexus, and they will enter into middle cranial cavity. Then they will move anteriorly and ultimately they are going to supply dilator pupillae. All right, but if there is damage to sympathetic fibers, it is called Horner syndrome. You also call it as oculosympathetic paralysis. Now, what will be the features of oculosympathetic paralysis? So there will be first and foremost anhidrosis. Anhidrosis is loss of sweating. Okay, there will be miosis. Miosis is pupillary constriction. Why pupillary constriction? Because the dilator pupillae is affected. There will be ptosis. Ptosis, mind you, there are two muscles in the upper eyelid, main muscles. Of course, third is orbicularis oculi. We are not thinking about it right now. So the levator palpebrae superioris receives its nerve supply from which nerve? Oculomotor nerve, third cranial nerve, which has nothing to do with this. But there is another muscle which is your Muller's muscle that receives its supply via sympathetic fibers. But in this disease, sympathetic fibers are affected. So there will be paralysis of the Muller's muscle. But mind you, Muller's muscle help in keeping the eyelid erect by just 2 millimeter. Have you understood? By just 2 millimeter. So this ptosis will not be full ptosis. It will be partial ptosis, and it is due to involvement of Muller's muscle. So what will be the answer, boys and girls? It is clear cut exophthalmos. There is no exophthalmos. In fact, it is believed that there is enophthalmos. But enophthalmos, I again repeat, it is not true enophthalmos. Actually, due to partial ptosis, the eyeball appears to have sunk in when actually it hasn't. So if I may ask you, which of the following is not seen in Horner syndrome? Anhidrosis, miosis, ptosis, enophthalmos. Then also you will mark enophthalmos. But if I may ask you, which of the following is not seen in Horner syndrome? There is anhidrosis, ptosis, enophthalmos and mydriasis. In that case, you will mark mydriasis. So based on the options, you have to pick up the right answer for yourself. Okay, so that is about your Horner syndrome. A patient presents with proptosis that increases when bending down. And what is the most likely diagnosis? When the patient is bending down, probably there is collection of the blood which is happening posterior to the eyeball, which is pushing the eyeball further downwards. Hai na? So in which condition it can happen? This is a clear-cut answer. This is orbital varices. So it is also known as which proptosis? This is your intermittent. Multiple times we have done it in the class. Intermittent proptosis. Okay, since we are doing intermittent proptosis, can you tell me another proptosis which is your pulsatile proptosis? Pulsatile proptosis is when the eyeball moves to and fro, to and fro, to and fro. You must have seen the video that I usually show in my lectures. Pulsatile proptosis can be seen in cavernous cortico fistula, in cavernous carotidofistula. So if there is fistula between internal carotid artery and cavernous sinus. Also sphenoid dysplasia, fracture of roof of orbit. So these are the causes that can cause your pulsatile proptosis. It moves with the heartbeat. Thuk, 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 thuk. Okay. A patient visits emergency with history of trauma and following radiological images obtained has been asked multiple times. So can you appreciate what is this sign? This is nearly, we have done like 10-20 times and it has been repeated like multiple times. So this is typical your teardrop sign. Teardrop sign which you see on X-ray. And why there is teardrop sign? It is actually herniation of intraorbital soft tissue. When there is herniation of intraorbital soft tissue into the sinus, so it appears like a tear, right? Now this is seen in which condition? Orbital floor fracture, or you can call inferior wall fracture of the orbit typically. So this is your teardrop sign. Can you tell me the thinnest wall of the orbit? The thinnest wall of the orbit is medial wall. Yes, but the most common fractured wall in blunt trauma, most common fractured wall in blunt trauma is your inferior wall. All right. Oh, so we are done. Okay, so guys, these were the questions which were asked in your FMGE Jan 2025 examination. So the idea of this video is to help you during your nth hour revision. So I hope you enjoyed it. If you are finding it to be going at 1.5x 2x, don't worry, you can slow it down and take the notes. Each and every line that I have told you is important. All right, thank you very much. And yes, if you want to follow me on Instagram, that is I_Manish. You can also follow me on Telegram, and I usually keep putting questions, keep doing quizzes on my Telegram channel, and the name of the channel is Ophthalmology by Dr. Manish Chhabra. Ophthalmology by Dr. Manish Chhabra. All right, looking forward to connect with you, looking forward to have your feedbacks about the sessions which you are attending. Thank you.